إن شاء الله دقائق ونبدأ المحاضرة. اللي يسأل بس انتظر إن شاء الله دقائق ونبدأ المحاضرة. اللي يسأل بس انتظر طيب. السلام عليكم ورحمة الله وبركاته. الله يعطيكم العافية جميعا. الصوت واضح إن شاء الله للجميع. نرحب فيكم اليوم مع مبادرة الإدارة العامة للأشعة للتدريب اونلاين عن بعد. اليوم يشرفنا الاستاذ عادل الزهراني، باحث الدكتوراه في جامعه امبريال كوليج. يعطيه العافيه وشكرا لوقته. حيتكلم ان شاء الله عن lower limb burns system duplex assessment، حيتكلم عن الدي في تي، الالتراساوند، خصوصا في الايام هذه نتكلم عن كورونا. في كلام اليوم عن انه كورونا لها تسبب بعض التجلطات، فكويس ان نبدا اليوم على الالتراساوند. فالاستاذ عادل سمعني، الله يعطيك العافيه.
اسمعك حبيبي، تسمعني الان؟
العافيه، المايك لك.
شكرا جزيلا استاذ باسم. بسم الله الرحمن الرحيم. Thank you very much for being here, and thanks for giving me this opportunity to present today's presentation, which is about the lower limb venous systems duplex assessment. As a way of introduction, my name is Adil Zahrani. I mainly work as a vascular ultrasonographer at King Abdullah Medical City in the Holy Capital. And I am a PhD researcher here in Imperial College London. Before we get started, let me first flag out a few points that I believe they are quite important points to start with. The point number one is the presentation itself is quite narrowed and too much concentrated towards certain points. So if you bear with me for this upcoming 30 or an hour, maximum of an hour, you would be, inshallah, get your mind refreshed and gain some new knowledge about scanning DVTs using ultrasound. The second point I would like to mention is this is a part of our commitment with the administration as a continuous professional development. And we would like to take it as a friendly chat. So please feel free to ask a question, stop me whenever you want. Let's have it as a professional exchanging experiences and sharing knowledge altogether. Last and not least, I put more images and videos with the presentation. So to link the theoretical point with the clinical practice, that's in the online presentation. We cannot really link it to the clinical practice. So videos would help us to demonstrate what we're talking about in reality. Let's save some time and go through the presentation. That we will be going through the anatomical structures that's involved into our assessment. So what veins and from where to where. Also, we will be going through the common pathological cases we come across in a daily basis into our clinical practice. We will be going through scanning protocols that's being used in most advanced centers worldwide. Last and not least, we will be talking about examples, some normal and abnormal appearance in ultrasound. If we are talking about the venous systems for human lower limb, then we are dividing them into three groups. Group number one, which is the superficial system that consists of two main vessels, which are great saphenous vein and some people like to call it long saphenous vein. And the vessel number two here is a small saphenous or short saphenous vein in some countries and some centers. This is a part number one or group number one, which is the superficial system. The other system is the deep system, which consists of more vessels or more veins and starts with common femoral vein and superficial femoral vein. Nowadays, they call it femoral vein, and profunda veins, popliteal veins, and below knee veins. We're talking about anterior and posterior peroneal veins. Bear in mind here, the superficial femoral vein is not part of superficial system. It's the one vessels within the deep system, but for some reason, they share the same description. The other point here is below knee, each artery is accompanied by two veins. So anterior and posterior would be able to see in longitudinal, if you scan your patient below knee vessels, you would see an artery line in the middle between the venous, either anterior and posterior venous. So this is the normal appearance of the veins below the knee. And the group number three here is the perforators, which are the network connecting the superficial system with the deep system. So the perforators carrying the flow from the superficial system and drains the flow within the deep system, not all the way around. If it gets the wrong direction, then we're talking about something else, and we're talking about reflux within the perforators. So basically 3 main groups: superficial system, deep system, and perforators. The presentation itself has been divided into 2 parts. So we will be going through the part number 1 now, which is the deep venous system. We will be starting with the anatomical structures that's involved into our assessments. But before that, let's take the left side of human body anatomy here. It starts with the IVC at this point here, which is divided into 2 main vessels: right iliac veins and left iliac vein. Left iliac vein then bifurcates into 2 internal and external iliac vein. External iliac vein ends where common femoral vein starts, and then bifurcates into 2: profunda or deep femorous vein, and superficial femoral vein, or femoral vein nowadays they call it. And they join a adductor canal or Hunter canal. Beyond that canal is the popliteal area, which is in the knee crease or level. Then we are coming through the anterior tibial veins, which will be 2, like I said, and then tibioperoneal trunk, then divided into 2 vessels: peroneal veins and posterior tibial veins. In ultrasound, if we're scanning patients for a deep system, then we're mainly talking about common femoral vein as a starting point, and until the distal part of anterior and posterior tibial veins. Here is just a nice example of how valve within the venous system functioning. Well, patency and competency is great in here. We can tell that's the deep system as it lies just posteriorly to an artery here, and allowing the flow to go towards the heart, but preventing the flow from going backwards and cause a reflux or any other consequences. So this is the normal and healthy valve within a venous system. Now, if we're talking about a deep vein thrombosis or a DVT, then we mainly referring that into a formation of a blood clot that occurs within the venous system in a deep system, and affected the particular vessels. Sometimes that's a DVT, if it's quite acute and fresh, it sometimes gets broken down into parts and causes something and or consequences that's unwanted consequences for our patients. We call it emboli. So if the that small part travels through the venous system, through the IVC until the heart, and then the heart pumps it into one of the pulmonary arteries or lung arteries, causes the total occlusion or total blockage or partial blockage within the arteries in our lungs or the patient's lung.
اخوي عادل.
اوكي، الصوت واضح الان؟
اي واضح الان، يعطيك العافيه، تفضل.
ما ادري وين وقفنا عند ايش، بس اوكي. احنا وقفنا هنا في السلايد هذه، صحيح؟
Yes.
Okay.
DV thrombosis.
The pulmonary embolism is the consequences or the complications of the DVT or showering DVT emboli that travels through the IVC, like I said. And the DVT, anyone can get it, either male, female, young, but it's more common with the elderly people. So it's quite important to diagnose our patients accurately to prevent a pulmonary embolism. Short clip to demonstrate how is the mechanism within the human body in case of pulmonary embolism occurs.
If you are immobile for an extended period of time because of surgery, pregnancy, illness, or travel, you may be at risk for deep vein thrombosis, or DVT, a condition where a blood clot forms in a deep vein in the body, typically the leg. Unlike arteries, which rely on the heart to force blood through them, veins transport blood with the help of muscle contractions while you move and walk. Veins also have valves that keep blood from flowing backward and pooling in your arms and legs. When you are immobile for an extended period, your venous circulation slows down. As a result, clotting factors in the blood may cause the slow-moving blood to clump together, forming a blood clot or thrombus. This condition is called deep vein thrombosis, or DVT. Common symptoms of DVT include swelling of the leg or a vein in the leg, pain or tenderness in the area, increased warmth in the skin, and red or discolored skin. In some DVT cases, a blood clot may detach from a deep vein and join the bloodstream. The clot travels from the deep veins of the leg, through the veins of the abdomen, into the heart, and finally lodges in the pulmonary artery or its branches, blocking blood flow to the lungs. This condition, called pulmonary embolism, is very serious and may permanently damage a portion of the lung. If a clot is large, or if there are many clots, pulmonary embolism may also cause death. If you experience symptoms of PE, please tell your doctor or nurse immediately. These symptoms may include shortness of breath, a sudden sharp pain in the chest, a feeling of lightheadedness or dizziness, rapid or irregular heartbeat, or coughing that produces blood. To help prevent deep vein thrombosis and pulmonary embolism, your doctor may require you to do the following. Walk around periodically to keep the blood from pooling in your legs. Wear compression stockings, and take anti-clotting medication.
Okay, so like I said, it's quite important to diagnose our patients accurately in order to prevent the unwanted consequences or complications that patients may have.
PowerPoint. ما في PowerPoint, huh?
Okay, leads them to other medical journey. So the risk factors here is the several risk factors. To be honest, a lot of risk factors, but I put the common risk factors here, which are the prolonged bed rest, those who have the fractures and requiring lying down for a long period of time, or major surgery, particularly within the pelvis or the abdominal area. And the long distance traveling, people who, for example, book a flight and fly from Saudi to, for example, United States of America, then they spend 12 or 14 hours within the plane without movement or with minimal movement, are quite at high risk of having or developing DVT. Paralyzed people, pregnancy is quite associated with the DVT, and particularly during the pregnancy and after 3 months from giving birth, and damages within the vessels in the venous system, either by trauma, RTAs, ATC, whatever, and then thrombophlebitis, which is the inflammation within the superficial system, in the venous superficial system in particular, but it can occur within the deep system as well. Malignancy or any other type of cancers. Oral contraceptive is quite associated, particularly the old version of contraceptive. Family history of DVT or PE, ages, risk increases if the age increase. Obesity is always an obstacle in front of us and causes a DVT sometimes because the limited movement with those who are obese. And the catheter location or insertion in patients, for example, requiring central line or permacath for dialysis or whatsoever, they get DVT in their deep vein system. So quite a lot of risk factors leading to DVT. The common signs and symptoms are mainly 4 signs and symptoms. Bear in mind that when I say sign, then I refer to something that we as professionals observe in our patients. And symptoms is what patients feel. We cannot really tell what's the symptoms unless the patient talks to us and tell us that they feel pain, they feel tenderness. But using our vision, we could tell that there is a swelling, which is a signs of DVT. So basically swelling, tenderness and pain, warm in the skin, and also discoloration within the affected leg. If you notice here, the right leg is quite swollen compared to the left side here. And also the color here is changed in comparison to the left one. Diagnosis tools, testers, D-dimer as a first line, and physicians or referrer like to rely on duplex ultrasound. It's a gold standard for diagnosing DVT. And also at some circumstances or some conditions or syndromes, we do require a venography or MRI to rule out some particular circumstances or particular cases. We have got something called Wells score criteria. So it's basically if you have 2 points present in new patients, then new patients likely developing or having DVT. If it's less than 2 points, then new patients are likely having DVT or not developing DVT. For example, if we have a patient that we know that that patient has a cancer and then present with the, for example, a swollen leg, then this is 2 points, then our patient is likely to develop DVT. Another example of a patient had a major surgery and present with the pain within their leg and swelling as well. This is 3 points. So our patient is likely developing DVT. This is called Wells score criteria. Now let's move into the technical part and let me get my mind and yours refreshed about the equipment selection and why we do select a particular transducer for a specific examination. We mainly rely on ultrasound on a linear transducer and curved transducer. The linear transducer here produces a high frequency rate and therefore gives us a better image resolution and better image quality, but unfortunately it doesn't go deeper than a certain point. So we use it mainly for superficial structures. The curved transducer here produces low frequency rate and therefore gives us less image quality, but it does penetrate longer than linear transducer. So basically, and in general, we use linear transducer or probe for superficial structures, and we use curved transducer for deep structures like abdominal scan, or at some circumstances, if we've got a obese patients, we use a curved transducer even for vascular assessment. Now let's get a quick refreshment about the description. And we all know that the distal part is a word that describes the structures away from the heart. So this is a distal part of the arm, and this is midpoint of the arm, and this is a proximal part of the arm. If we're talking about the medial aspect, then we're referring to the central line of our patients. If we say laterally or lateral aspect, then we're referring to the edges of the patients. And of course, the head direction here is a superior and inferior if you were referring it to patients' feet. But you might, some physicians like to get at the direction based on the flow direction. So the venous system would be this one proximal, and this part here would be distal because of the flow direction in terms of relation to the heart. To avoid this confusion, just I would urge you and advise you to use, for example, if we scan a DVT, a superficial femoral vein, let's refer this point here as the upper level of the thigh and mid level and above knee or above knee level here, or below knee level if you want to describe something you find. Again, refreshment about the echogenicity. We've got an anechoic appearance here, which is usually with the flow or fluid or whatsoever, like blood. Hyperechoic is quite less than the anechoic here, but sometimes we link it with the acute thrombus. We'll go through that in a minute. And then hyperechoic, which is also bright than the hypoechoic. Isoechoic here is quite blurry, and we do not really use it to describe something mainly in the vascular system. Hyperechoic, like I said, is quite bright and sticks with the chronic or old DVT, or for example, calcified plaque or something like that, or stones within the gallbladder, for example. We call it reflective or with the acoustic shadowing. So this is the common echogenicity that we use to describe our finding in ultrasound. Again, more important point here is this little mark. Each probe has, or transducer has a marker here, and this mark corresponds to the top left of the screen, and therefore this side here should be always to patient's right when you scan your patients in transfers, and always to patient's head if you scan your patients along attitudinal. We'll go through the examples next slide, but I just find it quite a good chance to just get our mind refreshed that this mark corresponds to a mark in top left of our screens. So in transfers, if we are scanning our patients, like I said, this is a right mark towards the patient's right, and therefore corresponds to the right top here, and therefore this side should be the right side of our patients, and this is of course would be the left side of our patients. The near field here would be anterior, which is the patient's tummy or abdominal surface, and this is the patient's back or posterior aspect, sorry. The sagittal longitudinal view here, if we take the marker towards a patient's head, then the corresponds to the right marker here in the top left of our screen, and therefore this is the superior aspect, inferior aspect, near field, which is anteriorly, and posterior, which is the patient's back. I hope this is quite clear, because it's quite important to know the orientation of your probe and the orientation of your ultrasound screen. Now, what we're looking for and what we do really use in assessing vascular ultrasonography in general, or venous system in particular, we do rely on a B mode and color mode, and also we do use a pulse wave or spectral pulse wave for assessing a DVT. B mode is quite associated with the compressibility, and color mode is associated with the color filling within the vessels, to make sure that there is no thrombus, and also pulse wave to tell us whether the positive or negative spectral waveform in our screen. Bear in mind the compressibility here is a gold standard, but at some circumstances we do not really tend to scan our patients, and even gentle compression is not permitted with the quite acute or floating thrombus, because this may cause other consequences, other unwanted consequences. So this kind of protocol is quite busy. A slide here. Do not freak out about this, because we start basically from the unguinan area, from the common femoral vein, and our landmark there is the Mickey Mouse view, which consists of the common femoral vein and superficial femoral vein and long saphenous vein, or terminal valve line here, or the saphenofemoral junction. Then we do apply a color Doppler here to make sure that's the vessels here filling within the lumen with no problem, with no evidence of DVT. And then we go longitudinally to assess the vessels with the spectral waveform. It's entirely up to you if you want to scan a B mode first from the common femoral vein until the distal part, or if you want to use the compressibility, then move your probe into longitudinal and use the other modes for assessing the DVT. But at the end of the study, you've got to scan the common femoral vein and superficial femoral vein or femoral vein, and deep or profunda vein, also popliteal vein, and below knees arteries, posterior, anterior, and peroneal veins, sorry, not on arteries. So this is the structures that we need to get them assessed in order to scan our patients for DVT. The protocol to start from the common femoral vein all the way down until distal part, including superficial femoral vein and profunda vein, popliteal vein, posterior and anterior peroneal veins as well. Like I said, the floating thrombus are quite risky. If you note here, this bit here is like someone calling you to just give a gentle compression in order to let it go to the heart, and then from the heart pumps to one of the arteries and get the arteries occluded and cause really, really unwanted and serious life-threatening consequences. Another example of a floating thrombus. Now he is flagging out for the sonographer. He is quite professional. He just uses the color flow to make sure that the thrombus, floating thrombus is there, and he did not compress the thrombus. If you see here, another example is it's barely stationary there, wants to go away. You just need someone to encourage it to go to elsewhere in the human body and cause life-threatening consequences like pulmonary embolism. So if you come across one of these floating thrombus, please do not compress your patient. Do not use the compressibility technique. It's more than enough to rely on a B mode. It's quite clear here. If you notice here, the thrombus, you can tell if you want to apply, like the gentleman here, just apply the color mode to make sure that the thrombus is there. That's more than enough. There is no need to take risk and rescue patients of having other consequences. Now, the normal examples, you would have your patients lying down with their knee slightly bent to avoid the muscle strain within the thigh. So it allows you to get some more compressibility within the thigh. So we start from this point here, which is the inguinal area or inguinal crease. And here it is pre-compression, and here is the common femoral while compressed is totally collapsed and wings out. You've got to scan each 2 centimeters from the upper thigh all the way until the popliteal vein. Each centimeter has to be compressed if there is no floating thrombus within the vessels. And this is the popliteal. There is a saying stating that pop on top always. So this is a popliteal vein lies above the popliteal artery, and it's totally collapsed or compressed within the compressibility technique. Here giving you an evidence of no thrombus. Below knees, like I said, we've got the 2 veins accompanying each artery. So this is an anterior posterior vein accompanying this artery here in the middle. And the other one here, which is might be the anterior and peroneal or posterior and peroneal veins. Let's see a short clip on how do we do 2-point evaluated for DVT. This is not a traditional and comprehensive study, but I found it quite useful to just demonstrate how DVT assessment is conducted.
So it's actually quite easy to do an ultrasound examination in the ED to determine if a patient has deep vein thrombosis. And this is a well-established practice of ultrasound. We're going to do a modified version of that for the ED exam, though. To set up for this examination, you want to tilt the gurney so that you're in a reverse Trendelenburg. So this encourages venous distension in the leg, so it's easier to visualize the veins with ultrasound. We're going to use a linear transducer for this examination, and the views that we do for this exam will just be in a transverse orientation only. So when you're setting up for this examination, make sure the orientation marker, again, is to the right. For this examination technique, we're going to use a compression technique where we just slightly compress the vein with some downward motion. When you set up the exam on the system, just select the exam key. Then from your menu, select the venous exam type and hit select. When you do this, you're optimizing the system so it's automatically configured for your best resolution of the veins. we're going to use a little bit of ultrasound gel, and we're going to assess two areas, the femoral area and the popliteal area. I'm going to start with the femoral area. We're going to place the ultrasound transducer at the inguinal crease in a transverse view. When I do this, immediately below the transducer in the ultrasound image, I'm going to see two anechoic structures. The one that's going to be more medial is the common femoral vein. The one that's more lateral is the common femoral artery. The way I can landmark this is by looking for the junction with the saphenous vein, or the long saphenous vein. And we see this emptying into the anterior aspect of the common femoral vein. And in this image, we actually see the venous valves separating the long saphenous and common femoral veins. So at this point, what I do is I just use my compression technique. So I just push with the transducer down until I see both walls of the vein coapt or touch and meet each other. If I get a complete coapt like this, I know there's nothing between those two walls. So there's no venous thrombosis in the vein. So again, just compress down until you see those two walls meet completely. You'll see that the artery does not compress and is pulsatile beside the vein. Now that you've identified your landmarks, you want to do a thorough evaluation of that area. So again, placing the transducer at the inguinal crease, we're going to compress the area of the common femoral vein. We want to move a few centimeters proximal to this, so superiorly on the body, and we'll start a compression technique, making sure that those walls collapse completely, and we just work through this area, compressing every centimeter. We see our common femoral vein and saph-fem junction here, and we can continue compressing just a few centimeters below this. On the ultrasound, we've seen the division to superficial femoral artery and profunda artery, just lateral to the vein. And then we should see the vein divide to femoral vein and profunda vein. Again, compressing all the way down until you see this junction. From here, I'm going to move down to the popliteal region. Just move the system down towards the knee, and we're going to actually go behind the knee, putting the transducer into the popliteal fossa. Once you've identified the popliteal artery and vein, mid-popliteal fossa level, you want to evaluate above and below this area to make sure you've evaluated all those areas for deep vein thrombosis. So we're going to start mid-level and just work our way superiorly in the leg to the superior aspect of the popliteal fossa, compressing all the way. We go up a few centimeters, and then we start to move down the leg, compressing into the inferior aspect of the popliteal fossa. Again, making sure that those vein walls actually touch and meet each other. So we know that there's no deep vein thrombosis that's fresh, which would be hypoechoic, would be difficult to see if we did not do this compression technique. Those are the two steps for assessing the leg for deep vein thrombosis. It's just these two evaluation points, but just make sure that you evaluate each area thoroughly and you do your compression technique completely.
So this is the quite concentrated and focused assessment into 2 points, either common femoral and throughout the superficial femoral vein until popliteal vein, using only one mode, which is the B mode or brightness mode, some people like to call it, and compressibility. But a traditional one, and the one we want you to do, is B mode and color mode and spectral waveform throughout the lower limb. Yes.
Yeah, just can you go back to the PowerPoint, please?
Okay.
So,
okay. Is that okay?
Yes.
Right. So the common limitations here is the opacity, always obstacles, and the severe edema. People who patients who presents with the swelling legs is quite difficult to scan, and people who presents with the wounds or fractures or structures around their legs that we can't get an access to assess the vessels. And how do we distinguish between an acute or chronic DVT? It's basically an acute DVT is homogeneous and filling the entire lumen, expanding the lumen, getting the size of the vessels slightly increased. And there is a minimal collaterals you may be coming across. And it's anechoic, so it's quite blurry, it's not really bright, it cannot shine to tell you it's there sometimes. And like I said, it's filling the entire lumen. But the chronic one is heterogeneous and also attached to vessels, to the vein wall, and it's quite bright. With the echogenicities is hyper-echoic, and you would be able to see some collaterals if you are moving surrounding the affected area. Examples of an acute DVT, if you look into this picture here, is expanding the vessels. The echogenicity here is slightly hyperechoic, partially compressed. I do not agree with the compressibility in case of an acute or fresh acute DVT or floating thrombus. And here is the longitudinal view for an acute thrombus. This is a nasty short clip from the superficial system going, looks like a subacute thrombus going into the deep system through one of the junctions. Either, I'm not really sure if it's the saphenofemoral junction or saphenopopliteal junction. One of them, the valve gets damaged and the snaky thrombus here is traveling to the deep system. Chronic DVT examples, if you look into that, it's quite attached to the wall and hyperechoic, bright, and more compressible vessels here gives you, because it's not filling the entire lumen or vein. Now, the common types of the spectral waveform, trying just to summarize it and save some time to not to get you bored, and I'm trying to just summarize things very quickly. If you notice here, this is a respiratory variation, which is normal, corresponds to a normal venous system with no evidence of the thrombus. So you get it confirmed by a B mode, color mode, and a spectral waveform, a confirmation by having this ideal spectral waveform. If you've got a continuous spectral waveform, then it tells you, although there is a color filling here, but it tells you that there is something either partial or complete occlusion proximally to this point here. And if you've got a rapid spectral waveform, then it represents a cardiac problem, either endocarditis or a CH. If this is the common, three common spectral waveform that we come across on a daily basis. Please bear in mind that there is non-thrombotic abnormalities and finding that we come across sometimes. The patients refer to a vascular lab or radiology department for having the DVT excluded. Then we find out the appearance here, which is the subcutaneous cellulitis. This is a typical cobblestones appearance. And also Baker's cyst, we always find them in elderly patients behind the knee. And you need to make sure that it's not compressing or giving some pressure to the vessels, either an arterial or venous system. And you could apply a color filling here just to make sure that there is no blood supply within this cystic lesion or Baker's cyst. A normal hematoma here can be found anywhere, and also lymph nodes, particularly at the upper thigh, we find this inflamed and enlarged. For example, if let me say a patient had the total knee replacement or a hip replacement and get infected, the lymph node or the lymph system starts to respond to that and gets enlarged with the blood supply through the lymph nodes. So you need to make sure that you are diagnosing your patients accurately and in accordance to what's being required. We have got something called post-thrombotic syndrome, or PTS, and this is basically the consequences and persistence complications of having DVT, where patients gets treated well from the DVT, but the signs and also the symptoms still last for longer than usual, and therefore we refer it as or describe it as a syndrome, because it's the persistence, signs and symptoms as the complications or consequences of having a DVT. Now we've got another syndrome I would like you to know, because it's quite important to know and just expand your knowledge about the vascular system here. Methanol Syndrome, which is the compression caused by a right iliac artery compresses the left iliac vein here and causing other problems in there. It's just a compression, mainly occurs in a female than a male, and happens during the pregnancy as well, due to the pressure. And also, Methanol syndrome occurs in people or patients between 20 and 40, in accordance to recent scientific paperwork published in 2013 and 14 as well. And also in 2015, a study tells that the Methanol syndromes occurs twice often trusted sources in the women compared to men. So more likely at high risk of having Methanol syndrome than men. This is just from different angle to show you what the vascular surgeon or interventional radiologist can do and help in patients with Methanol syndrome. This is a pre-treatment, and this is after endovascular procedure, putting a stent and keeping the left iliac vein open and patent. I think this is part one. We've done from part one. I think it's a good chance to have some questions while we're still fresh within the deep system. Then we'll be having like a minute or two break, and then we'll carry on the superficial system. So Bassem, it's yours if you have any questions. I'm not really familiar with Zoom. I can't see if there's anyone raising hands or wants to start a discussion or question. Please take over.
يعطيك العافية. شباب اللي عنده أي سؤال, any question, please just raise hand, or you can type it in the chat. I can see it for the first part. Yes, Rania Mohammed, I will unmute you. Mic is yours, Rania. Rania. Miss Rania. Okay. Dr. Jamila.
السلام عليكم.
عليكم السلام.
Just I have a question for the best position for the pregnant ladies, especially in the third trimester. Most of them, they cannot lie down straight because the back pain. So we have to also come on for difficult breathing. So we have to raise the head, or we will put them in the lateral position. Sometimes it's difficult to examine the vein in that position. So what do you recommend for the pregnant?
Thank you very much for your question. It's a good question. You've got the position called Flowers position, where you can tilt to a couch slightly, patients lying down, or just bring the head or chest slightly up, semi-sitting, or even you can scan them standing if you would, using a color mode and spectral waveform. You don't have to compress in such as cases, because the color mode and spectral waveform are more than enough to give you a confirmation whether your patient has a DVT or not.
Good. Dr. Salah Ad-Din, I will unmute you now. Dr. Salah Ad-Din. You can unmute yourself now. Yes, Dr. Salah Ad-Din.
Hi everyone, can you hear me?
Yes, you can hear. We can hear you.
Excellent. First of all, thank you very much, Adil, for the very well presentation in the first part, at least. I got a few questions, if you don't mind. The first thing, you have mentioned that MRI is one of the choices or scanning modalities for DVTs and maybe chronic vein insufficiency. Could you just highlight at what condition ultrasound is inaccurate and requires other imaging modalities?
Excellent and brilliant question. We've just mentioned the Methanol Syndrome. Ultrasound is 90% unable to detect this syndrome. It's quite high and requires more experience, and you have got to link the patient's presentation and history with your findings. So you scan your patient, you find no cellulitis, the varicose vein is still there, and the pain is still there, and patients complains of things around there, and you still can't find nothing using ultrasound. When you scan your patient in suspicion of Methanol syndrome using MRI, then it would be clearly shown that the compression is there. So some circumstances like venogram and MRI are quite important modalities for scanning patients with certain circumstances and certain conditions.
That's great. Thank you very much. And I have another 2 questions, if you don't mind. Do we have time for it, or should we keep on going?
As in control.
Just last question, and we'll be back, inshallah, at the end of the presentation.
Yeah,
right. So I will just get you with the last question then. Yes.
Yes, please.
Yes. In terms of acute and chronic thrombosis, I'm sure you come across about in some report mentioning subacute thrombosis. Can you define or highlight what subacute means in such cases?
Okay, like I said, the acute is hypoechoic and the chronic is hyperechoic, so pride. And subacute DVT, when the ultrasound features are of neither acute DVT nor chronic post-thrombotic changes. So you can't use the criteria of an acute to apply it for that particular finding, and you can't describe it as a chronic, which is not quite pride, not hyperechoic and not also hypoechoic, in between of them. The other point you could link, you always talk to your patients, and your patients will tell you that the swelling and the symptoms last for more than 14 days or not, because the acute thrombus is mainly considered within the 14 days. If it exceeds 14 days, then we consider it as a chronic DVT.
Excellent. Thank you very much.
Thank you.
Thank you. Thank you. Shall we continue?
I think we go back in 3 minutes. Is that okay? Or do you want to carry on now? It's entirely up to you.
Okay, okay, 1 minute or 2 minutes.
Okay, we'll be back in, for example, 25 past 9. Okay, 9 here and 25 past the 11. Okay, so 3 minutes.
Okay, 3 minutes. يعطيكم العافيه. فور ناو ممكن اذا في احد، يمكن اول محاضره سويناها كان في اسئله كثيره على الانفكشن كنترول مع الدكتور احمد، وعدناكم ان شاء الله نرجع لكم بالاجابات. اي احد عنده اسئله زياده ممكن يرسلها على الايميل mohrad@moh.gov.sa او على حسابات التويتر اللي نزلناها. For any participant here, he want to ask question about infection control, especially through COVID-19. Could you please just send this question through email mohrad@moh.gov.sa. We'll be back inshallah with you within 2-3 days or within a week for the answers of questions. ان شاء الله حيكون في محاضره كذلك عن انفكشن كنترول حيقدمونها الزملاء من الاداره العامه لمكافحه العدوى. تواصلنا معهم وهم على اتم الاستعداد للاجابه، واتم الاستعداد كذلك للاجابه على الاسئله. اللي يسأل عن محاضرات الانفكشن إن شاء الله قريبة إن شاء الله. أول نحتاج الأسئلة منكم، نشوف الأسئلة الموجودة منزلونها جميعا، وحيكون لها رد، وحيكون في محاضرة. المحاضر بس هو تو الآن يفطر، فنعطيه بس دقيقتين الفطور، هو خارج السعودية فيفطر ويرجع لنا إن شاء الله. أعطينا 3 دقائق.
Okay. Let's start the second part about the superficial venous systems. Like I said, we have divided the venous systems into 3 systems: the deep system, superficial system, and perforators. So we'll be talking now about the superficial system. And once we say superficial system, then we mainly refer it to a condition called a reflux. Do not get scared about a lot of anatomical structures here. It's basically just to have a picture here in the middle combined with the deep system here and superficial system here. If we scan a DVT, then we are mainly referring to a deep system. If we are scanning for a reflux or varicose veins, then we are scanning the superficial system, which consists of long saphenous vein or great saphenous vein, and a short saphenous vein or a small saphenous vein. In between them, connecting the deep system, the superficial system to the deep system, we've got several and various perforators. And like I said, the normal direction is from the superficial system to the deep system, not vice versa. And also the junctions here, saphenofemoral junction and saphenopopliteal junctions at this point here have to be assessed during the examination. So mainly we are looking for 2 main vessels: long saphenous vein or great saphenous vein, and short saphenous vein or a small saphenous vein with the junctions and any incompetent or dilated perforators in between of them. You don't have necessarily to know the perforator's name because they keep changing now. This is the upper thigh. It used to be Hunterian perforator, but it's quite useful to know the locations and the normal direction and the connection between superficial system and the deep system. So if you notice here with me, it's quite a healthy clip in there, the flow coming towards the heart with the right direction, and the perforators here taking the flow from the superficial system and drains into the deep system. So the normal is cephalic, going to patient's heart, to patient's head, and from superficial to the deep system, not all the way around. And also most normal perforators diameter measurement, some POCs says 2.5 and some they says 3, but the maximum of that is 3. If you find a 3 and it's competent with no insufficiency of reflux, then that's fine, because patients differ from others. And also the left side here is example of incompetency in the superficial system within the perforator is taking it from the deep system all the way to the superficial system, causing dilatation within the superficial system here. And this is why and where we see visible varicose veins. If you notice the valve here, functioning well, opening and closing perfectly, but here is damaged and allowing the flow to take around here and go backwards. From the different angle, you could see healthy and well functioning valve, preventing flow from going backward, but here with the dilatation, the valve gets damaged. This condition is called reflux, and the reflux is not varicose vein. The reflux is the cause, or one of the varicose vein causes, but the varicose vein is the where you see the visible varicose vein in the patient's skin. So the common risk factors, pregnancy, there are a lot of risk factors, but the common ones are pregnancy and elderly people and prolonged standing and also sitting. So those who work like teachers standing too much, they are at high risk of having varicose veins. And also people who sit in their office or pilots, for example, they are at high risk of having a varicose veins because they're sitting for a long period of times. And then the circulation is not encouraged to go back to the heart because the muscle contractions and the pressure within the vein is not going to the zero by encouraging the flow to go to the heart, and then the valve gets damaged. The varicose veins are more common in women than men, particularly during the pregnancy. And for those who, like I said, standing for a long period of time. Stages of varicose veins, we've got the normal one here. It's quite clear and smooth. Stage 1 with the spider veins. So you could notice a spider vein in there. Stage 2 with the nodes and bulgy nodes alongside with the spider veins, and they start to discolorate the skin in there. And the stage 4, which is the advanced stage here with the edema and swelling and the spider veins along with the visible, and you could notice that if you put your hand in there, quite bulgy varicose vein. The most advanced one is the one with the ulceration here, which is the quite important to be treated, diagnosed first and treated with patients with vasculitis or with the ulceration based on the venous system. So what we're looking for, thrombus. If you scan any patient for varicose vein, then you have to assess for DVT, because there is no point treating your patient from varicose while the more important conditions, which is DVT, is there. So exclude the thrombus first, and then venous insufficiency, if there is any reflux within the venous systems, venous patency as well. Some people, like I said, the venous system is quite small, sometimes disappears at some points, the joining network, other network within the venous system. And also the perforators. Measure the perforator and see the flow direction within the perforator. Are they taking the flow from the superficial system to the deep system, or taking it from the deep system to the superficial system? Quite important points we have to mention and scan. And like I said, we have got the two main vessels within the superficial systems, the long saphenous vein, or some people like to call it great saphenous vein, and short saphenous vein or small saphenous vein. The long saphenous vein runs from the medial malleolus in the medial aspect of the patient's body or lower limb, and then it starts from inguinal area and raises from the saphenopopliteal junction from the common femoral vein. The short saphenous vein starts below the knee and raises from the saphenopopliteal junction. Bear in mind, some patients do not have a saphenopopliteal junction, and therefore do not panic. You're not finding the saphenopopliteal junction. If you chase the short saphenous vein all the way up, you're going to find it either in the mid-thigh, or there is no even junction. So that's quite normal variation in human bodies. So if you want to scan your patient, you've got to have them a standing position here, and start from this point here. Please start from above the knee. Use it as a landmark, because if you start from longinal area, then you may get confused and mislead between the anterior axillary or posterior axillary tibial veins and long saphenous vein. But if you start from above the knee, then you are quite sure you find in a landmark called Egyptian eye, which long saphenous lies in between the saphenous sheets, and you could chase it all the way until the junction here, and all the way until you like to scan your patient at distal parts here. In the short saphenous, you would be able to see the similar landmark here, which is the Egyptian eye, where the saphenous sheets, the vessels lies in between them, and you scan your patient from the saphenopopliteal junction all the way until the lower level of the leg. Using the augmentation or technique here, the normal with the spectral waveform would be like this, not exceeding the baseline or exceeding it for less than 0.5 seconds. And if there is a reflux, then the reflux will be coming from the above the baseline and giving you the grade of the reflux, while mild or moderate or significant or severe reflux. So please start scanning your patient from above the knee all the way up and go below the knee and identify your landmark using Egyptian eye. The scanning protocol, I've just mentioned that, but you need to scan that in longitudinal using 3 essential modes, B modes, and transfers, and also you've got to scan your patient using a color mode, using a longitudinal view, and squeezing or applying a augmentation distal to you, the area being assessed, and using also a spectral waveform to see the spectral waveform, whether it's below this baseline or going above it, the baseline or above it. And then the long saphenous vein has to be assessed with the saphenofemoral junction, and the short saphenous vein has to be assessed with the saphenopopliteal junction. Any dilated or reflux perforators have also to be mentioned within your report using the diameter measurement and the flow direction within the vessels and the perforators. And the study for chronic venous insufficiency have to include the deep system, consists of the common femoral vein and superficial femoral vein and profunda vein, demonstrating patency and competency as well, and popliteal vein as well to see the patency and the competency, alongside with the both junctions, superficial femoral junction and superficial femoral, saphenofemoral junction and saphenopopliteal junction within the superficial system. Like I said, any other perforators or any incompetent perforators have to be mentioned and reported. Any other finding or accidentally finding like a Peyko's test or a cellulitis or whatsoever you come across, please do mention that, because it's quite useful to lead your patient to the right medical journey. Venous reflux grading. So if you've got a negative result out of the study here, then you refer on it because the reflux is less than 0.5 seconds. If it's positive, then we divided that into 4 or 3 main categories here: mild, moderate, and severe. Mild from 0.5 to 2 seconds, and from 2 seconds to 3 seconds, we consider it as a moderate, and more than 3 seconds is a severe reflux. And according to CEAP, systematic patients has to be treated regardless if the grade of reflux is mild or moderate or severe, because if the guidelines within the comprehensive classification system for chronic venous disorders stated that. And the venous reflux depends on the degree of the cough. So if you've got a young lady squeezing E, mostly young men then find it difficult to give a power to encourage the flow to go to the heart and then to assess the reflux. So the best way for assessing the reflux, if you want to get the accurate result about the classification of the reflux grading here, is to use a photoplethysmography or PPG modality in order to assess the reflux time. Let's have this as an example here. So this is a severe or significant reflux going above the baseline here. And if you count with me here, 1, 2, 3, 4, the time is more than 4 seconds, then refer into severe reflux. But here is likely to be less than 2 seconds if we count 1, 2. So it's like a moderate reflux or mild to moderate reflux. Here we can find the long saphenous vein lying in the medial aspect, like I said, and it starts from saphenofemoral junction here all the way till the level of the above knee level, and is scanning in transverse and longitudinal, and the short saphenous within the calf, and scan it from saphenopopliteal junction all the way down. And here is the appearance of the short saphenous vein with the Egyptian eye, and here is the appearance of the long saphenous vein with an Egyptian eye. Here is the saphenofemoral junction, and this is the terminal valve, we call it. And here is the popliteal or saphenopopliteal junction, where short saphenous or small saphenous raises and comes from this bit here all the way down. Two examples of the reflux using the color and also spectral waveform. The spectral waveform here is the valve closure here is quite nice and brilliant with no problem at all. And here is giving us an evidence of reflux because it goes above the baseline. Here is the augmentation time or the squeezing time, and this is the release time where it goes all the way opposite and downwards. Bear in mind that some patients have the, it's quite rare, but it's good to know that the Kleppel syndrome is the congenital abnormality. So the people born with this syndrome or congenital abnormality, which is only known at birth if the patient presents or baby, a newborn baby presents with a sign called port wine stain, like discoloration here and just change in the color, skin color here. And with time, they develop the varicose veins, really snaky and nasty varicose veins with a lot of tortuosity and a lot of network surrounding the thigh and leg. It's quite rare, but it's quite good to know that there is a Kleppel syndrome patients that you may come across in your career. This is a short clip about performing a reflux assessment. We will go through this, a short clip, and then we will carry on for the last 5 or 10 minutes.
Let's go over some important points about this study, points that are key to giving an accurate interpretation. Point number 1, we need to determine whether or not there is a blood clot. Here's the first image of the common femoral with the vein open and closed, the junction, the femoral vein, popliteal, small saphenous, and great saphenous all appear to be fully compressible. Now that we are assured that the study is completely negative for deep venous thrombosis, or superficial venous thrombosis for that matter, our next point is to determine whether or not there is reflux. As you can see here, the right common femoral, augmentation, and valsalva appear to be completely normal, as does the augmentation for the saphenofemoral junction, profunda, femoral vein, popliteal, and calf veins. You can see the sonographer actually just does a color Doppler image of the calf veins to prove there's the augmentation and there's no reflux determined or flow determined after release of the calf. Competency is also proven at the anterior lateral branch of the great saphenous and the great saphenous through the thigh. However, having looked through the entire study, you should have noticed that the sonographer performed provocative maneuvers, both lying down and standing. Therefore, the images here in the proximal calf, mid, and distal calf, which all appear to be completely normal, are negated by showing the Doppler signal, at least in the calf, with the patient standing, as you can see here. So once the sonographer stands the patient, it invokes a reflux signal. As you see here at mid-calf and distal calf, there's a great deal of reflux occurring in the great saphenous. So knowing that the person likely had varicose veins, mainly in the calf, the sonographer chose to stand the person And now with provocative maneuvers employed while standing, reflux is identified. You will also want to mention the reflux identified in the small saphenous vein as seen here, as well as mentioning that the reflux appears to only be present at the proximal through mid-calf. However, the distal small saphenous appears competent. Our third point is to mention any perforators that are identified. As you can see here, there's an augmentation with flow going in the correct direction away from the probe. However, upon release, you see the color red moving back toward the superficial tissue, which would be considered reflux. The sonographer mentions a diameter measurement and then moves on to a tributary that is also identified lateral to the shin. And we can see a color augmentation and a release picture showing, again, reflux. The last point you will want to mention in your impression is that this was a unilateral study and is proper procedure to just show a compression and flow in the contralateral common femoral. Actually, by the standards of the IAC, we really need to show just the flow, but we tend to also show a compression picture just to make sure and be clear that there was no thrombus identified in the contralateral common femoral and that flow appears normal.
Here are some references for those who want to go and read more. Please feel free to ask questions or contact our administration at any time, or contact me directly with no barriers or any problem. I do apologize for starting slightly late, and I do apologize for running out of time, taking your time for this presentation. Takes longer than expected. And the time now is yours for any questions or discussion. Use either language, Arabic or English. You just feel free of this part. Thank you.
يعطيك العافية وشكرا على المحاضرة القيمة هذه. As usual, please, if you have any question, just raise hand or just type in the chat. اللي يسأل عن استلام الشهادات as usual لما تسجلون سجلوا اسمكم، نفس الاسم اللي بتسجلونه حيكون موجود إن شاء الله على الشهادة، حتجيكم مباشرة على الإيميل. الدكتور أحمد مدير العام، يعطيك العافية.
السلام عليكم. يعطيك العافية دكتور عادل. الصراحة محاضرة جدا قيمة. I'm sorry I didn't join early, but I was having another meeting. But I could arrange to join at late the meeting. From what I saw, it is so beneficial, very informative and fruitful informations. First of all, I would like to thank you for giving us part of your time to present this, and may Allah accept your work and prayers, inshallah, during this holy month. Second, I would like to emphasize on something, that most of the sonographers or technologists or even radiologists, they face a lot of difficulties when they are to perform male extremity exams. I would like just to emphasize on one point, that ultrasound sonography is operator dependent, and with practice you can master it. So whatever will be difficult in the first day, believe me, after a few months, it will be just a piece of cake. It's just a matter to have a good protocol, good landmark, good positioning, and you will be able to detect everything. Thank you, Dr. Adil.
Thank you very much, Dr. Ahmed, for your encouragements and the beautiful words here. And the pleasure is mine, sir. And we are one team and one family to provide what it takes in order to provide the high standards to our end users or patients. The quality has to be raised, and we are doing really well, but we need to encourage other professionals to do more work. And like I said, this is part of our continuous professional development that we will be conducting, inshallah, in the future. Thank you very much once again.
Okay, we have a question here. Said, what's first modality for DVT? I think meaning what's the first modality suggested for scanning for DVT?
What's the question again, Basim?
What is the first modality suggested for scanning DVT?
If I got the question right, we go through a blood test called the D-dimer. The patients has been referred to the laboratory for D-dimer. Then the second line is the gold standard here, which is the ultrasound. Is it for the excluding or confirming DVT or not?
Okay. Another question said, does the echogenicity differs from a chronic and acute?
It does, because the acute echogenicity will be hypoechoic, so which is slightly darker than the chronic, but the chronic will be more bright, and also we call it a hyperechoic and attached to the wall alongside with other criteria. But in terms of the echogenicity, yes, it does show up as a brighter than acute DVT.
Another question here said, in case of floating thrombosis, if suspected, what is my precautions in scanning veins?
If you see in a B mode the floating thrombus, then you can use the color mode, like the middle short clip I demonstrated earlier. Or just to stop at that point, tell the physician or the referrer that there is a floating thrombus. I'm not going to take risk to myself or to the patient's life, and encourage that floating thrombus to travel or shower further. So stop at that point, let them do their job, but use is not to compress in suspicion of the floating or quite fresh DVT.
Another question here asking about conversion on chronic DVT. Is it safe?
Chronic DVT?
Yes.
It's a condition, medical condition anyways, but if it's a stable condition, if it gets there for a long period of time, then that's fine. But patients who do have recurrent DVT, interventional radiologist or vascular surgeon may do have to put the IVC filter to prevent the showering thrombus or amply to go to the heart and cause the pulmonary embolism. But if it's the once chronic DVT and the stable DVT, that's fine. They require them to just follow up with the ultrasound and to make sure that's the stability of the thrombus.
Another question here, may I ask about patient who has severe leg edema and obese, and I cannot linear to see the blood flow.
Yeah, like I said, the linear transducer produces a high frequency rate, but it doesn't go deeper than certain point. So what you need to do is to change and swap using the curved transducer, the one we use for abdominal structures, kidneys, liver, whatsoever, and start assess your patient using that, because it gives you better penetration and it goes deeper into a patient's body.
Good. Another question here said, does the venous produce wave when the patient is standing?
I'm not really sure what they're referring to, but if you, in terms of this kind of reflux, if you stand your patients and put some squeeze distal to the area being assessed, yes, it does get changed. And if it's normal, without even augmentation, the respiratory variation would be present within the spectral waveform. And if you have a healthy patients and they squeeze them distally, then the flow would go backward and they would see it with the spectral waveform. It's quite clear.
Another question here said, can DVT be missed on ECG examination?
The DVT, if it's quite fresh and might be barely seen using conventional ultrasound. So like what Dr. Ahmed has mentioned earlier, is kind of experience. You need to increase your gain and play with other modes, like using color modes, spectral wet form, and play around with your patients using your probe, some maneuver. Then you would be able to distinguish the patients either having or does not have any DVT. But yes, it's quite tricky sometimes. If it's quite fresh and hypoechoic, it's quite tricky and it can't be missed.
Another question here, how to measure the time of reflex?
All we say here is the estimation near the confirmation, because the ultrasound is has a high sensitivity and a low specificity. And what we mean by that is it does tell you that something wrong, but it doesn't necessarily tell you what that wrong is. So the grade of the reflux, the vascular surgeon or interventional radiologist, if a patient presents with a varicose vein or reflux without visible varicose vein, but the patient has persistent pain or complications, then the patient will be treated using AVLT or whatsoever of the other treatment options. So regardless the grade of reflux, either mild or moderate or severe or significant, patients has to be treated. But in terms of measuring the time, yes, if you calculate the baseline, the seconds, and you would be able to see the time of reflux or using the automatic measurement.
Good. Another question here said, is grading should be mentioned in the report?
It's quite useful to mention it, but sometimes, like I said, the referrer would take an action anyways, either mild or a significant reflux. So it's very good to mention and to have your comprehensive report handed in.
Okay. Can I consider the vein wall thickness as a partial thrombosis or not?
The vein wall is, if it's coming through the entire vessels, then there's no problem to get worried about it. If it's not a local or focal thicker point, but if the entire vein is thicker, then the patient may present with a variation, which is normal variation. But you need to scan your patient and make sure that the vessel is patent and the lumen is open all the way until the even IVC, if you want to make sure that the patient is okay and having no evidence of DVT.
What is the best probe angle used in Doppler imaging and why?
This is quite a long answer because it relies on a physics point of view, but I will tell you that the angle of insulation has not to be exceeding 60 degrees, because if it goes more than 60 degrees, then you're playing with the equations and physics and the measurement will not be accurate. So do not play with your angle of insulation. If you want to get the angle correction, just use the steering box or use minus 60 degrees while you scan your patients, but do not exceed 60 degrees.
Okay. يعطيك العافية دكتور عادل. طبعا for any question you can ask through the email and we'll get back to you either through the email. Our next lecture inshallah will be next Wednesday inshallah with Dr. Wamid. دكتور عادل شكرا لك من الأعماق، شكرا لجهدك ووقتك، وشكرا للحضور جميعا، يعطيكم العافية. زي ما قلنا الأسئلة يعطيكم العافية ممكن تسألونها في الإيميل المتبقية. كذلك اللي يسأل على الشهادات حتكون إن شاء الله هترسل لكم على إيميلكم على نفس التسجيل اللي سجلتوه في بداية المحاضرة أو تسجيل الرابط. المحاضرة القادمة إن شاء الله يوم الأربعاء القادم الساعة 10:30. شكرا دكتور عادل، يعطيكم العافية ونشوفكم إن شاء الله الأربعاء.
شكرا حبيبي، الله يحفظكم جميعا وإلى لقاء قريب. السلام عليكم.